Okay, we're gonna get started now. Good morning, good afternoon, and good evening to anyone joining us today. My name is Alan Dominguez, and on behalf of the International Dysphagia Diet Standardization Initiative, it's my pleasure to welcome you all to the webinar titled Promoting Meaningful Computer Information Exchange Between Patient Care Sites, Inclusion of IDDSI in SNOMED CT. Some quick housekeeping before we begin. This webinar is being recorded and will be available on the IDDSI YouTube channel in a couple of days. So we invite you to share that with anyone who might be interested in this content. Second, all participants who join us today are in listen-only mode, which means that the panelists cannot hear or see you, and your microphone and video will remain off for the session. However, we invite you to submit your questions, and you can do that using the questions button on the middle of your menu bar of the GoToWebinar app or the website if that is how you're joining us today. And the panelists will then address these questions at the end of the presentation when we will have about 15 to 20 minutes for a Q&A period. IDDSI does not currently offer continuing education units, but a certificate of attendance will be emailed to anyone attending this session automatically. So you do not have to email us to request this certificate. It will be emailed in a couple of hours to the email that you use to register if you're attending this live session. And lastly, we'd like to thank our very generous sponsors who allow the work of IDDSI implementation to continue around the world. These sponsors do not have any influence on the work that IDDSI does in implementation and the activities that we carry around the world. So that is it for housekeeping. Now it is my pleasure to introduce Peter Lam, who is the chairperson and CEO of IDDSI International. Hi, Peter, welcome.
Thank you very much, Alan. Good day to everyone. I am thrilled to be here with our presenters today. And I'd like to just give you a little background about how this webinar came about. Back in 2022, and in fact, in 2021, there were some discussions that started to take place because of requests from users of IDDSI and the IDDSI community, folks like yourselves, um, to the SNOMED CT organizers to say, hey, is there any way to integrate IDDSI terminology into electronic health records that would be consistently used around the world? And we are thrilled that SNOMED International was open to a discussion with IDDSI. And for those of you who don't know who SNOMED International is, SNOMED International is a not-for-profit organization that owns and develops SNOMED CT. So they are a comprehensive healthcare terminology product that just helps us to have consistent terminology that can be used by all users of SNOMED CT. And this is a really, really powerful tool, and it's a great collaboration between our two organizations because we are both striving for standardization to improve patient safety. So happy to say that in September of 2022, a collaborative agreement was signed between SNOMED CT and IDDSI. And well, we're thrilled that IDDSI is now in electronic medical records all around the world, thanks to the wonderful people at SNOMED. So that's a bit of background for you. And what I'd like to do now is let the experts in the webinar tell you more about SNOMED. So on that note, I think, Elaine, I'm handing it over to you. Is that correct?
Yes, thank you very much. And hello, everyone. And thank you for this opportunity to talk to you. So just to go over the learning objectives for today's session, we're going to explain the rationale for including the IDDSI concepts in SNOMED CT and illustrate through a case example of how structured nutrition orders and terminology facilitate communication and improved quality of care across all healthcare settings, such as from the inpatient to a post-acute setting. And we're also going to describe the role of nutrition standards to support electronic health records. Next.
Great,
And I
thanks,
think
Elaine.
Alan's going to explain about Slido.
Yes, thank you. So Elaine has prepared this poll. So we're going to invite you all to use your mobile devices to scan that QR code that appears on your screen, or you can also do it using a website and your any website you're using, just entering slido.com and then entering 2824798. And I see some people already responding, so we will just give it a minute or so to get some responses, and then we can discuss the results.
You can see the responses coming in. So nutrition and dietetics practitioners in the lead so far. We've got some dysphagia clinicians and other.
All right, maybe
Yeah,
we'll give it another 20 seconds or so. Okay.
Okay there. Yeah, so predominantly clinicians. Yeah, thank you for participating in the poll. Next slide, Alan. Okay, so I'm here just to tell you a bit about SNOMED CT and IDDSI and the introduction to SNOMED CT of the IDDSI concepts. And what I'd like to do, next slide please, Alan, is just to tell you a bit about SNOMED International. Peter's already given you a little idea of what we're about, and explain something about SNOMED CT, why SNOMED CT, so why use SNOMED CT, and then a bit more specifically about the IDDSI content in SNOMED CT. Next, please, Alan. So SNOMED International, as Peter mentioned, we're a not-for-profit organisation that owns and maintains SNOMED CT. Our headquarters are in London. We're a virtual workforce across the world, and our member dues are based on gross national income. With the world's most comprehensive clinical terminology, and as well as actually producing the terminology itself, SNOMED CT, we also produce a number of other products. A global patient set, which is a free set of SNOMED, and we also map to other standards. And we also produce SNOMED terminology for the International Patient Summary, as well as some open source tooling to support people. In terms of services, we have a dedicated customer support. We have implementation support, which is extremely important. We have translation, education, product documentation and guidance, and also we have our own help desk. We're very much member focused. We've got 49 members globally and active stakeholder engagement. Next, please, Alan. So just to explain about our vision, we'd like clinical terminologies to be used globally, and we're well on the way to that with the number of members that we have. And that will result in better health and improved patient outcomes if supported by one language of health. And our mission is to sustainably produce a global clinical vocabulary and other services that enables the clear exchange and analysis of health information for all. Next, please, Alan. Just a quick one, this one. So about SNOMED CT. Next. Thanks. So as I mentioned, it's the world's most comprehensive multilingual clinical language. So the authors involved in SNOMED CT in producing the terminology research evidence-based articles and journals to make sure SNOMED content is accurately modelled and clinically validated. So imagine, even within a single hospital, clinicians may use different terms, names, abbreviations, all for the same thing. And this variation only grows internationally. That can make it pretty tricky to ensure we're all talking about the same thing. And SNOMED helps solve this by allowing multiple descriptions for the same idea. So it makes it easier to search and retrieve information. As I mentioned before, SNOMED also maps to various international standards, such as ICD, MEDRA, Orphanet, as an example. And these maps are created by specialists who have deep knowledge of both the source and the target standards. So the increasing use of SNOMED in more than 80 countries across the world is showing fantastic possibilities and benefits for SNOMED in making it easier for different systems to share and use information effectively. Thank you. So how is SNOMED CT created? We've got 4 basic principles guiding the development of clinical content. Now, medical terminologies are complex, and SNOMED is no exception. The SNOMED community is globally inclusive, with active collaboration across various areas from domain experts. We have a SNOMED editorial guide, which enforces rules to ensure the terminology is developed in a standardised and controlled manner. And it's supported by technical tools as well as peer reviews from fellow authors. And with each release, we focus on improving quality, making the process transparent and open to feedback from our users. And our goal is to make SNOMED easy to use and adopt. So we provide the open source tools, support services and assistance to help individuals, countries and vendors understand and implement SNOMED smoothly. Next. Thank you. So how does SNOMED CT work? So when integrated into an electronic health record, SNOMED allows consistent, comprehensive representation of clinical information. It enables professionals to use different terms with the same meaning. And SNOMED CT concepts have unique definitions, so every concept is unique, formal logic, and are organised into hierarchies. And this is using 3 types of components, which you can see on the screen there. We have concepts, which represent the clinical thought, each with a unique numeric ID. Then we have descriptions, which connect human readable terms to these concepts, and relationships, which link related concepts to each other. As an example, inadequate intake of iron is a child of inadequate mineral intake. So there's that relationship, that hierarchical relationship there. Thank you. Next. So why SNOMED CT? So why are we all here? Well, electronic health records are a significant step forward, but we also want to make them more meaningful. SNOMED CT helps identify key facts in large amounts of data and enables meaning-based retrieval for better access to clinical information. It connects the EHR to trusted clinical knowledge, supporting informed decision-making. Next. So while electronic health records improve communication and access, SNOMED ensures the information remains meaningful and useful. Next. And the important thing is, as well as the human being human readable to all of us, SNOMED also represents the clinical meanings in a way that's processable by computers. So that increases the analytical properties of SNOMED. Next. So how is SNOMED CT used? SNOMED CT plays a big role in different areas of healthcare. It helps with recording and organising clinical data in healthcare systems and making and sharing patient information between care providers much easier. At the point of care, it supports clinical decision making and real-time data and reporting. And in research, SNOMED's essential for both clinical and scientific studies. It's also used for tracking trends and analysing healthcare system performance. On a larger scale, it helps with population level analysis, like monitoring drug safety and conducting clinical audits. Overall, SNOMED CT ensures that healthcare data is consistent, shareable, and useful across a wide range of applications. Next, please. So I'd like to just explain the benefits of SNOMED CT. For individuals, SNOMED ensures consistent clinical information during consultations. It supports decision-making with real-time advice and makes it easier to share information across different care teams. It also allows for something like a comprehensive search to identify patients who might need follow-up or further interventions, and it works across multiple languages. For populations, SNOMED also helps to manage population health by providing accurate information, reducing errors, and supporting clinical research. It also improves care audits by giving access to detailed clinical records. And in summary, SNOMED enhances both individual care and population level improvements, driving evidence-based healthcare. Next, please. So I'd like to show you now some of the IDDSI content developed in SNOMED CT to give you some concrete examples. Okay, so the IDDSI framework is represented within SNOMED CT hierarchies. And I've given some example of those hierarchies and examples of the concepts. So we have an assessment scale concept, which would be used by system suppliers to electronically populate the form for the assessment that you're actually doing. So the IDDSI initiative framework. You can also record the procedure for the activity for actually doing the assessment itself. So there's a concept for assessment using International Dysphagia Diet Standardization Initiative Framework. You'll be pleased to know the abbreviation IDDSI is also present within SNOMED. And then what we have is we call an observable. An observable in SNOMED is something that you observe or ask. It's a question. So you're able to record something like the IDDSI drinks level for that patient or the IDDSI food level for the patient, which are very important observations. Next. We also have the IDDSI framework levels, and all of the levels are included in SNOMED CT. We have a high level, what we call a grouper concept, and beneath that are the 11 subtypes representing each of the levels. So example, we have the IDDSI thin level 0 concept. What we've also done with these levels is add the definitions for each level is described in the framework, which includes reference to things like flow test, fork drip test, spoon tilt, etc. Next. Also, it was important to include the IDDSI functional diet scale within SNOMED CT. And in a similar way to the framework, we have the assessment for populating the form and the procedure for recording or planning the activity. And then the observable, which you can record the score on that functional diet scale. So that gives you a flavour of what's in SNOMED CT. Thank you. It was a pleasure to actually go through that with you, and it's a pleasure to work with everybody on this project. I'd like to introduce Donna Patel, who will be looking at some real-world use of IDDSI SNOMED CT content. Over to you, Donna.
Thank you, Elaine. Hello, everyone. It's great to be here today. I'm here to share with you a case example. It's just a short illustration of the power of structured and coded terminology, but I thought we would ground it in an actual case example so that you can see how this might be used in real life. There is no protected health information here, so this is all completely made up. I am going to be using some definitions, so I thought I would go over those first. Dysphagia clinician is the professional responsible for the therapy and recommendations related to swallowing. In some countries, this is the speech language pathologist, but in other countries, it can be an occupational therapist, for example. Nutrition and dietetics practitioner. This is the professional responsible for the nutrition care. In the United States, this would be the RDN, an NDTR. In other countries, these are similarly credentialed professionals. In some countries, it may also include food service personnel and food service order entry facilities. And the last one is client. The client is the subject of record. Sometimes this is referred to as the patient, and this can also include family and or caregivers. So the case that I'm going to share with you, this is a 70-year-old client, married, no significant health history. The client transitioned from an inpatient hospital to a rehabilitation facility after a stroke and subarachnoid hemorrhage. The client's inpatient course was complicated by severe pneumonia, intubation, and NPO status for 4 of the 18-day hospital stay. The hospital discharge communication to the rehab was sent via fax and included the diet order, minced and moist, level 5, and MT2 drinks level. So now we're launching another poll.
Thanks, Donna. So I'll invite everyone to do the same process. You can just scan the QR code at the top left with your mobile device or join on the browser, slido.com, and using the number at the bottom, 2824798, and you can start participating whenever you're ready. And we'll give it a couple minutes.
So in this situation, which concept is not consistent with the drinks level that was in the discharge communication, MT2 drinks level?
Maybe we'll give it another 30 seconds, Donna, and then we can discuss the results.
Sure. All right, I'll go ahead. Not surprisingly, this is a crowd who knows their IDDSI diet levels. So yes, it is the moderately thick yellow item that is inconsistent with the discharge order. If you could move it, Alan, to the next slide, that would be great. So the IDDSI as a community is doing amazing work to make sure that the diet levels for food and drinks are understandable and clear. Use of more than one idea, so the description, the level, the color, is strongly encouraged for client safety. Yet it's possible that human error or a gap in understanding of the abbreviations could create an error in the new diet order. I'm sure a lot of you went through that when you were doing training with staff, helping familiarize everyone with the potential different descriptions available. All of these on the left are approved abbreviations that can be used. What's interesting though is if you look at trying to ensure that computers can talk to each other and provide smooth, unambiguous transitions, the SNOMED identifier, the concept on the right, would be the safest way to ensure that the individual is receiving the concept that the individual is supposed to receive. These concept ID numbers are completely unique for a particular concept. And as you can see, the moderately thick yellow is the one that is different. All the other descriptors are consistent with the discharge order. Next, please. So it's not a surprise to many of you who work in this area that this particular client was discharged on a Friday in the evening from the hospital to the rehab facility. The rehab nutrition order was written for an IDDSI pureed level food, green food, and extremely thick level 4 drinks. On Sunday, there's a referral to the dysphagia clinician and the nutrition and dietetics practitioner. Next, please. The rehab dysphagia clinician evaluation reveals that the hospital discharge communication, minced and moist level 5 and MT2 drinks level, was either not seen or there was a possible concern because of the person's recent stroke, that a more conservative order for IDDSI level 4 was used. It also could be that, the fax was lost. It was sent to the rehab facility, but perhaps got lost in communication or was delayed in its provision to people who might be writing orders for that person's admission. So the dysphagia clinician conducts their evaluation and agrees with the original discharge order, the IDDSI minced and moist level 5 food, and the IDDSI mildly thick level 2 drinks. So they either recommend or order that change. They initiate therapy and care coordination with the nutrition and dietetics practitioner. Next, please. So in this situation, then the nutrition and dietetics practitioner sees the patient and finds two nutrition problems. These are from the nutrition care process terminology. And we have unintended weight loss due to increased energy expenditure and NPO status as evidenced by a 4% body weight loss compared to the outpatient physician visit 3.5 weeks ago. Inadequate oral intake related to low acceptance of pureed foods and thickened drinks, as evidenced by an intake of less than 25% of pureed foods and drinks at meals since admission to the rehab facility. The nutrition and dietetics practitioner and the dysphagia clinician discuss the client along with the new diet order. The nutrition and dietetics practitioner recommends and implements a high-calorie, high-protein supplement twice a day between meals consistent with the new diet order. And the two professionals, having seen this happen number of times, recommend a quality improvement project. If you think about this, they frequently see individuals who come from hospitals on one particular diet order, and they receive a different diet order upon admission to the rehab facility. And they want to evaluate a couple of things. One, is there a delay or a lag in the communication? Or is the diet order that's being ordered at the rehab actually the accurate diet order based on the client's needs? So they initiate a quality improvement project so that they can smooth those transitions for individuals who are coming from outside of their facility. Next slide, please. So I think this audience who have championed and embraced standardized terminology, you can see some of the obvious benefits and opportunities of structured data in electronic health record communications. Depending upon how far along you are in this integration in your EHR, it may also pose some challenges. Please know there's not a perfect electronic health record terminology or structure. This is a journey, and the value of structured data are many. If we look at structured data, we have much more consistent and clear communication that's supportive and granular for expressing findings for the individual and across disciplines. Open text communication certainly can be available if there is a need to support more in-depth communication. Front-facing display that professionals see can be modified to meet each practitioner needs. When behind the scenes, then, there can be machine-readable, discrete codes and terms that can be there to support the data capture. This promotes better and more meaningful data exchange and data aggregation. So things like, if you want to know on average how quickly do clients improve their intake from 25% of meals to 75% of meals, this is much easier to capture with structured ideas than having free text boxes to capture the information. Or how many days does it take for an individual to move between IDDSI levels, for example? The ability to query data like this really demands that there is a structured data capture so that you can conduct this kind of powerful analysis. It's not possible with everything in text boxes. Does this mean that there's no unstructured data at all in electronic health records? Absolutely not. It certainly can bring rich information, but it should be only used in small instances so that we have the ability to capture and see the impact of our care on individual clients. Next slide, please. So a little bit about the nutrition care process terminology and our work with SNOMED. So in early 2010, actually, the committee who was working on the nutrition care process terminology reached out to SNOMED, and we started our collaboration at that point. Beginning in 2017 is when we started including some of the nutrition care process terminology in the US extension of SNOMED. And then in 2018, 2019 is when the content in the nutrition care process terminology was then promoted to the international edition for SNOMED CT, meaning that in any country, the concept, like the one that Elaine mentioned, the inadequate intake of iron, is available across the world. So dietitians who are practicing in Sweden and Australia and other places around the world can all use the same concept to mean the same thing. In 2020 then, SNOMED and the Academy and CDR signed a collaboration to include all of the nutrition care process terminology concepts that we can in SNOMED CT as of the 2020 edition for NCPT. So almost all of the content, including everything you saw for IDDSI, the observables and the interventions, are included in SNOMED CT. Our collaboration with SNOMED has been terrific for the nutrition care process terminology, and it really helps in terms of implementations for the nutrition care process. To help facilitate this even more, SNOMED has developed, with our input, a SNOMED NCPT reference set. In 2024, this included all of the nutrition problems in NCPT, so all of the nutrition diagnoses. And in 2025, it will include all of the nutrition diagnoses and the nutrition intervention concepts. And that will include the IDDSI diet concepts. Those will be released in April of 2025. These reference sets list the discrete coding terminology for use in electronic health records, and it helps dietitians all speak the same language and share nutrition interventions and results. The reference set makes EHR implementations and updates easier by providing the exact list of concepts that nutrition and dietetic practitioners may use, and a reference set can also guide quality measure developers and those implementing quality initiatives, because it will ensure that they properly only use codes available within the scope of nutrition terminology. The reference set may also help with data extraction for research purposes when used in conjunction with a formal research model. Now I'm going to turn this over to Michelle to discuss how terminology and standards work together to support interoperability. Michelle?
Thank you, Donna. So we're going to talk about healthcare interoperability. So what is that? It is the ability of two or more health information systems sharing, using, and exchanging data seamlessly. So, for example, you go to a lab for a blood test. The lab then securely transmit those test results to your doctor's EMR or EHR system. Your doctor reviews the results and then uploads them to your patient portal. So that's going through various systems with health information being exchanged and shared. Another example is your primary care physician needs to send a referral. So they utilize a secure system that transmits your healthcare summary. You know, there might be some images, CT scan images in there. There might be medications. There might be labs that are relevant. And they send this directly to a specialist. So again, that's an example of an exchange of healthcare information or healthcare interoperability. But in order to do that, these systems that are exchanging this information, they must have an idea of what is being exchanged, what is it supposed to look like, what does it mean, etc. Next slide. So I'm going to use the term standards throughout this presentation. So let's define what standards are. So data standards are like the rules. They tell us how to structure the data, what kind of information should be included, how to label it, and it ensures that everyone understands the data in the same way. And so how does data standards and terminology relate? So all the stuff that terminology that was previously mentioned, well, terminology is the language that we use to describe the data. So for example, as you can see on this screen, a standard for recording medication allergy is that, so the rule is that it needs to have a specific drug name and you have to indicate the reaction. And so the terminology could reference a SNOMED CT code for whatever allergy it is. So for example, penicillin allergy. So essentially, when everyone is using the same standard, or the data becomes more consistent, easier to understand and analyze. So we've briefly reviewed data standards and terminology and how they relate, but let's talk about how this data is exchanged. So next slide. So healthcare data exchange is super powerful. I think Donna mentioned that earlier. It allows your medical history, or your patient or client's medical history, kind of follow them through and navigate through the healthcare system. It provides, a means of securing your information, whether it's allergies or diets or test results, from system to system to system. So the benefits are pretty amazing. It's better care coordination. Doctors or clinicians can work together more efficiently. Streamline processes. It leads to smoother treatment plans and fewer errors or any kind of mix-ups. Plus, having all your information readily available can really help avoid unnecessary testing or medication use, or even access, being able to go back and read the last results from your, lab tests a few months ago or a few years ago. However, it does come with, its challenges and hurdles. This area is evolving every day. So some of the current challenges, different hospitals and clinics might use different systems. Some companies are not compatible yet. The terminology might be different between facilities, or interpreted differently between facilities. But again, this is all evolving, right? And we're adjusting as time is going on. And so even though there's these challenges, health data exchange is significant within healthcare. It's a game changer, from people carrying around, being wheeled in with a folder of their medical records as they go from place to place, or printing out items and handing it to patients or clients. So this is, we're moving in the right direction. So this is definitely something that we want to help contribute to and do as much as we can to further its advancements. So there's some organizations that are actually leading this effort. Next slide. So in the U.S., there is an organization, federal agency, the Assistant Secretary for Technology Policy, formerly known as, in conjunction with the Office of the National Coordinator for Health Information Technology. Ooh, it's long. ONC is how they're typically referred to, but they essentially coordinate U.S. efforts, so U.S. national efforts to implement, promote, use, and advance health information technology and electronic exchange of health information. So you can see from the graphic there some of the activities and things that they do. So they do EHR certification standards. They, develop different standards for electronic health information exchange. They set some policies. So their overall objective is to advance and establish expectations for, for the healthcare arena. But yes, they work nationally on U.S. Efforts, but they also have a hand in some of the international efforts that are going on. Next slide. One of them, partnerships, I should say, or collaboratives that they are involved in is the Global Digital Health Partnership, so GDHP. So it's a hub, essentially, for sharing the best way to use technology and data to improve healthcare. It connects various countries, and as you can see, currently the partnership consists of 36 countries and territories, but it's growing and it's changing each year. which is awesome. So they learn from each other, the various countries within this partnership. They develop new policies together. They predict trends within healthcare. So within the partnership, they have like work groups or initiatives within them, a variety of different ones. But some of them I'll share with you. One is clinical and health engagement. One is focused on research, and another one is interoperability. And as you see, some of the member countries, Australia, Canada, Brazil, Netherlands, are all putting in great efforts towards data standardization. One link, as you see there, was for the ONC, so the US agency, hosted an annual meeting in 2023 in Washington, D.C., and they had a representative from the Netherlands Ministry of Health and Welfare and Sports there sharing what they're doing. So giving us some insights essentially on what's working for them, what's not working, what they've actually, what some of the like benefits from being part of this global digital health partnership, like what they've received from it and some changes that they did to their systems to improve healthcare. And so you can, look up that information and watch the video, and it's really insightful to know like these efforts are international, and we're all trying to, focus on the same goal. So like I said, these organizations, this one and the one I previously mentioned, are working on like high level regulations and standards. But there's another group that also works on these efforts. Next slide. And that is something called HL7, Health Level 7 International. So they work on the ground. They're the nuts and bolts for data standardization. They develop standards and specifications for electronic healthcare information exchange, and they promote interoperability between various healthcare information systems. It's a nonprofit organization that is driven by volunteers from over 50 countries, and that membership continues to grow. So as you see on the map there, all the little blue dots are countries that are involved in and members of HL7, and they meet throughout the year several times, sometimes US locations, sometimes international locations, and they work on all these different efforts. They we are the Academy of Dietetics and Nutrition and the Commission on Dietetic Registration are gold member HL7 gold members. So we vote in the ballots, and there's several ballots that they have throughout the year. So we're able to put our input and voice into all these changes. We hold nutrition project calls monthly. And then we also participate in various special interest groups. So SNOMED, there's like patient care, public health, there's a variety of different ones. So we're trying to be as visible as possible and kind of put our input in this arena that is evolving every day. Next slide. So within HL7, there's like a new kid on the block in terms of data exchange. And it's something called FHIR, so Fast Healthcare Interoperability Resources. So FHIR is a set of rules or standards that helps different systems communicate effectively. And then they also have a method of exchanging this between systems, so requesting and exchanging data, like a messenger service of sorts. Within it, there's something called resources. So resources, you can kind of imagine, are like puzzle pieces. So specific pieces of healthcare information that kind of fit together. So one resource may be patient, another one might be condition, and then a nutrition order is another resource. So once all these puzzle pieces kind of go together, they're kind of telling a story and transmitting information between systems. So that's what FHIR kind of does. So as a clinician or someone that works in healthcare and not information technology, how or why is this all relevant? Well, next slide. Well, HL7 consists of work groups. So these are groups that are developing and maintaining these standards. And the Nutrition Project Group, they collaborate with HL7 consultants and the Commission on Dietetic Registration to work on these standards together. And so the work group that the Nutrition Project Group is under is called Orders and Observation. And some of the things that they've worked on over the years is developing nutrition FHIR standards. So there's 3 of them. So remember, these are like puzzle pieces, right? That kind of tell the story of and the data that is within the health record that's being exchanged. So we have nutrition order, nutrition intake, and nutrition product. Some of the other things that the Nutrition Project Group has worked on is the nutrition care domain analysis model. So what that is, it describes the required data and flow. I want to emphasize the flow of information that would be transmitted and exchanged within a nutrition order. So we're talking the oral diet, enteral nutrition, any oral supplements, food allergies, food preferences, anything that is required to safely provide patients or clients or residents with nutritional items. Another project that the Nutrition Group has worked on this is a long one, the Electronic Nutrition Care Process Record System Functional Profile. So we call it ENCPRS. And essentially it's EHR plus the nutrition care process and terminology. So it's a list of functions and criteria that would be needed for full integration of the nutrition care process and nutrition care process terminology into the EHR. And some good news to share, during one of the ballots this year, September ballot for HL7 that we participate in, we were able to reaffirm this document for another 5 years so that it's available for EHR systems to utilize. So when they're building out or conforming their systems to make sure that they're using the nutrition care process and nutrition care process terminology. So this is some of our current work and accomplishments that the Nutrition Project Group has been involved in, but we don't do this alone. We work in a variety of different projects and with a variety of different groups within HL7. So next slide, please. And these are some of the examples. So HL7 is, again, collaborative and very inclusive. One project group that we worked with is something called PASIO. So that's post-acute care interoperability. And they're within the patient care work group. Okay, so nutrition is in the orders and observation work group. Well, this is patient care work group. One of the projects we worked on with them is TOC, so transitions of care. So what that was, we identified information that a practitioner, so any practitioner, occupational therapist, speech language pathologist, physical therapist, dietitian, etc., would need during a transitions of care. So for example, a patient walks into a long-term care facility, what information would that practitioner or clinician need in order to do their job and to treat the patient? So we worked with them to identify, what would be required at that point in time. Another subgroup that we worked with within PASIO was personal functioning and engagement, PFE group. And essentially they focused on functional status, cognitive status, SLP, hearing, nutrition, those types of things. So things that a person that essentially relates to the person's ability to participate in activities and engage with their community or environment. This group tested our nutrition order FIRE resource that I mentioned previously in a testing event, in a test EHR with a test, client, to see how a nutrition order would be captured. And they utilize IDDSI food and drinks test patient. So we got to see in real time, oh, this is how it would present. This is how it would be captured and transferred within a EHR system. So that was pretty awesome work. So I'm gonna go over what a nutrition order looks like. It's a little intimidating, but I will try to be as non-technical as possible. So what you're seeing here is essentially the rules of what and how computer information should be exchanged for a nutrition order. So for example, a nutrition order should capture a patient, it should capture the order, the orderer who ordered it, the date and time, but it also can capture or should capture oral diet and feeding, nutritional supplement, among other things. So we're going to look a little closer into the oral diet section of the nutrition resource. So as you can see on the left-hand side of your screen, it says oral diet, and then underneath it is type. So which means the type of oral diet. And then if you look on the right side of your screen is the description of the type. And under there it says something called a binding. So a binding is a specific code or term that can be used in that field. So the field in this sense would be the type of oral diet. So this is how everything will relate to terminology standards, all right? So let's look at the binding of the diet codes that's on our screen there for oral diet type. Next. Thank you. So this is what the binding looks like. This is what it says. This is a value set. So a set of codes and terms that may be used for the oral. And on the page, you see there's a definition section that says codes that can be used to indicate the type of food being ordered for a patient. This value set is provided as a suggestive example, but it includes codes from SNOMED CT, such as the concept is a dietary regime. So for example, we can use any of the applicable codes in SNOMED under dietary regime, such as vegetarian diet or an IDDSI food or drinks level for the patient's oral diet, okay? Because we're using a standard code or term, there's no guesswork or confusion, as we may have seen in Donna's case example that was presented earlier. This is essentially like a pick list of things that they would utilize for communicating the nutrition order. So regardless of what country you're in or what facility you're in, if you're using a FIRE-based nutrition order resource, as we shown earlier, the information is consistent from facility to facility. All right, next slide. All right, so to kind of sum up everything, overall, healthcare interoperability, data exchange, data standardization is all the essential backbone of an effective EHR. So it enables consistent, accurate information. It helps decrease medical errors and improves patient safety. It really helps coordinate care for patients from birth to death. And it helps maintain accurate records within that span. So, and I think this was mentioned earlier, that it enhances analytics. We're able to extract the data easier. It makes the data more meaningful, which can really help make informed decisions. So, ultimately, the importance of all this that we went through essentially is it helps put the patient first. So, I know that was a lot of information that we just went through, but we do want to see where you guys are at, or what your thoughts on all this information. And we're positive that we'll get some good results from hearing all this. So we'll go to the next poll. So how likely are you to ensure that IDDSI concepts are structured and coded with SNOMED CT terminology in your EHR?
Great. So you can access the poll again through the QR code, or access it through your website, slido.com, with that code. And we invite you to participate. And we'll keep it open for a minute or so. While we're here, I'll just remind people attending that you can submit your questions using the questions button on the GoToWebinar panel. We're close to that part of the session where we'll be able to take your questions, and we'll direct them to the panelists. So thank you for doing that as well.
Okay, so I'm seeing a mix of responses, which is good to get an idea of where everyone is at. All right.
Yeah, it's pretty close, this one.
Yeah, it is. It is. All right. Well, thank you. Thank you, Alan. All right, so we want to encourage you to get involved with both local and international professionals to help champion the benefits of standardized data and terminology, especially in nutrition care. So by working together, we can make sure that essential resources like SNOMED CT, IDDSI, and other related terminology systems stay relevant, stay up to date, and stay accurate. We have a couple opportunities that are available for people to participate in. And again, you don't have to be a dietitian. You could be any clinician or healthcare professional, or even just interested in the work. We have a HL7 nutrition project call. Those meetings are the fourth Wednesday of each month at 1400 Central Time. And then you can also participate in the SNOMED Nutrition and Dietetics Clinical Reference Group, CRG, and they meet on the third Monday of each month at also at 1400 Central Time. All right, so we will move into our questions. Thank you guys for listening.
All right. Thank you, Michelle, Donna, Elaine. Wow. What amazing information you shared with our audience today. And it's it's amazing to see how much work takes place behind the scenes. We're hoping that the audience is just as impressed listening to all this work that happens in the background. There are times, I think, when we use systems like these and we don't realize all of the work that happens behind the scenes. So thank you once again for the amazing information that you shared. There are some questions that were pre-submitted, and we have a question from Kathy from Wisconsin. And the question is, when naming diets in the EHR, is it preferred to have all the IDDSI level, color, and descriptions? Who'd like to take that one?
You can take that. Yeah, so I've the information that I've read about IDDSI is that it's recommended to have at least 2 items, nothing less than that. So you need a level and a descriptor, but the color would also be incredibly helpful. Now, those don't appear in the SNOMED terminology because of the way the terminology is structured, but those are available in the nutrition care process terminology. And because the levels and the descriptors are unique, it really helps reinforce which particular diet, which food level or which drinks level is needed. So at least two of those 3 items are recommended.
Thank you, Donna. Yeah, and that's what we've always recommended for the use of IDDSI in general, even if it's not in electronic health record format. Ultimately, if we can use 2 out of the 3 unique identifiers for each textural level or thickness level, it just helps us to prevent errors in terms of communications, and that really is the purpose behind the development of the IDDSI framework and terminology. Elaine, I think I'll come to you and just ask, can you please explain to the audience here how a professional can determine if their healthcare setting actually uses SNOMED CT, please?
Okay, so the best thing is to speak to your IT department or your clinical informatics team. So they'll be able to tell you if the organisation has a license for SNOMED CT and also where it's used, which system it's used, which clinical areas, because it might not be introduced into every clinical area at once. It may be introduced to some areas first as an exploration. You can look for references to SNOMED CT in any documentation or training materials. If your organisation isn't currently implementing SNOMED CT, but you want to find out perhaps if your particular country is looking at implementation, then the details for each member country are on the SNOMED.org website, and that gives the contact information for each country so you can find out where your country's up to in terms of implementation of SNOMED.
Great, thank you very much, Elaine. Donna, I think I'll come to you with this one. You and Michelle advocate for structured terminology and standards. But how can our audience use the text fields to record client-specific information?
Yeah, I would say that most what's available in a lot of electronic health records right now is open text fields, right? So people are typing in a lot of information into text boxes. The hope is, as electronic health records evolve, that more content will be structured behind the scenes so that the data can be captured. Some vendors do this by adding standardized terminology like SNOMED or LOINC to aid in the data capture and analysis. But you also find some groups are using other ways, such as natural language processing, to analyze the information that's in text boxes. But that's still a very small number of EHRs. So you certainly can use free text, but as opportunities present themselves to have coded terminology, we strongly recommend it.
Great. Thank you, Donna. Thank you for clarifying that. Michelle, coming to you next. Who do we talk to in our setting about getting standardized nutrition? This is for other professionals, nutrition fields in our electronic health record.
Yeah, sure. So it can sound like a big task, right, to undertake, but it doesn't have to be. You can start small, just start within your department. So depending on what your position is, find a colleague or a superior, someone that is really passionate about improving documentation and standardization, and try to work with them to build support to try to drive this initiative forward. And then, review your existing documentation to see what areas could be improved to improve accuracy or efficiency, and, kind of start testing the waters a bit and getting some feedback. And then, again, it depends on your position. And then, you can further explore it, come up with a proposal or suggestions, seek out your IT department, just like Elaine mentioned. And there might be a documentation specialist within your facility. Every facility is really built a bit different. But when you start to capture the information that you have, improvements that you could do, and possible results, utilizing data that can really help support your changes for your EHR or your area that you're documenting in your fields.
Thanks, Michelle. It's always so lovely to hear such great alignment between IDDSI and SNOMED. We've always encouraged people to say that don't go it alone, right? It's always good to make sure that you have partners. And partners could mean just you and some other very enthusiastic person. Start those conversations and approach it in a way that is positive, collaborative, because a little sugar takes us a very long way, right? Elaine, I'm going to circle back to you because there was a question about, is it actually free to use SNOMED CT?
So SNOMED International doesn't charge for the use of SNOMED CT in member countries, so countries that have actually joined the SNOMED International family. There's no charge for SNOMED CT. Charges may apply for non-member countries, and again, that's based on the particular territory and what the use is for. Though we do offer free sets as well for non-member countries that for countries that are not able to afford some of the other fees for complete membership. So we do have that available. But if it's a member country, then no, there's no additional charge.
Great. Thank you, Elaine. Sorry to put you on the spot there.
That's all right.
And
Right.
as per all things we do in IDDSI, we always say we put the bold print up front, and we ask those questions just to make sure our webinar listeners are well aware. Hey, if we're going to use this, is there a cost to it? So, Donna, I'm going to come back to you and just ask you. In the case where you showed this hospital discharge order being sent via fax, it doesn't sound very interoperable. Can you expand on this, please?
You're absolutely right. It isn't very interoperable, is it? But that is the case in a lot of settings, that there are faxes that are being sent from inpatient hospitals to other sites to communicate the kind of care. And that's because the electronic health records don't communicate with each other. That's a process, that's a journey that everyone is undertaking, and that's why there are the standards that Michelle talked about, setting up the rules, and that's why we have terminology like the nutrition care process terminology in SNOMED to help identify what is it that is being provided as care for individuals. So we'll get there, but at this point, sometimes there are faxes that are being used.
Thanks, Donna. I feel like we're kind of dating ourselves when we talk about the use of fax. But we'll leave that for another day. Michelle, just one last question for you, if you don't mind. Are the nutrition order resources you mentioned currently in use?
Yeah, so I did mention it's being tested by the testing event that we had. by the Passio project, but also there is a large EHR company that is utilizing it and making it available via their method of exchange, so data exchange vehicle API that either other companies, mobile applications, or within their own EHR system can use. So that's what we know. What we don't know is if there's anyone else out there using it, and that's what we want to know. So any exposure or use of the resource is huge, and it keeps it mature, it keeps it accurate. So if anyone knows any companies that are using it, or you're interested in using it, please do and reach out to us and let us know, because we would love to go on whatever journey you're going on. We want to go on it with you.
Great. Hey, thanks, Michelle. What a wonderful time we've had together. Thank you for the amazing information. I'm going to pass it back to Alan to just close off this webinar.
Thanks so much, Peter. Yes, we've received some questions regarding getting in touch with the three presenters, and we do have contact information that we'll share in just a second. But before I get there, I just want to mention that IDDSI International has some events coming up. We have the Asia IDDSI conference in November of 2024, and you can access the registration through the QR code that appears on your screen. And we also have a EU IDDSI Congress next year in beautiful Florence, Italy. That'll be February of 2025. And if you are keen to joining us, you can also register using the QR code that appears on your screen. And whoops. There we go. And this is deep into next year, but we have an IDDSI Training Academy in September of 2025, and this is in Derby, UK. And registration information is upcoming, and we will share that with the IDDSI community on our website and on through the eBite as well. And here we go. This is what people were asking about. So you can get in touch with our presenters, info@snomed.org, quality@eatright.org, and cp@eatright.org. Thank you so much, Michelle, Elaine, and Donna, for this wonderful time. My goodness, having you here has been such a pleasure, and it's so interesting. And thank you. We can't thank you enough on behalf of IDDSI for sharing your expertise with us and everyone who attended this afternoon. As I said, the webinar is being recorded and will be available on the YouTube IDDSI channel shortly, and you will all be receiving a certificate of attendance in the next couple hours. But that is it for now. Thank you so much for joining us today, and I hope that you have a lovely day, afternoon, or evening, depending on where you're joining us. Thank you, and until next time.
Okay.